will start this. Thank you, David, for joining us today from Safe in Home. And we're very excited to have you tell us about your program.
Absolutely. Thank you for having me. I really appreciate the invite. I am going to share my screen here. There we go. And do you see the big Safe in Home logo? Great. Always got to make sure. So again, name of the company is Safe in Home. You can see we obviously have a website at safeinhome.com. The company started in 2017, have a little bit more than right around 1,800 people under support now. We're in about 13, maybe 14 states now. And we really do focus on the intellectual and developmental disability community. Vast majority, 95% plus of the people we support are someone with an intellectual developmental disability. We do support a few seniors as well, but we're really focused on that community. We are authorized by ODP in all 67 counties. Everything we do is covered under the Medicaid waivers that ODP uses if someone is on those waivers. We also have some people who just private pay for what we do if they're not on a waiver or on a waiting list or something else. You notice what our mission is there, to empower people. And that's really the bottom line of what we're trying to do here, is try and make people more independent, more self-directed. I've seen it really be a tool for people to gain confidence that, hey, I'm able to do some things on my own. I can be, on my own for some of the hours of the day. I can make some of my own decisions. And for a lot of people who've had support their whole life, that can be an extremely life-changing, satisfying change in their life. And I've seen people just really blossom from having this, from getting that confidence of being more independent, of getting the idea that they're more capable than maybe they ever thought they were, or were ever given credit for. So that's really our overriding goal and mission, is to make people more independent. And the driving sort of force behind that are the goals and outcomes of the person's ISP. That is obviously the document we're following, and those goals and outcomes that are enumerated in that document are one of our guiding principles for each person we support. So remote support, there's a lot of misconceptions about it. I've heard people say, oh, you guys are like a burglar alarm company, right? You put cameras in and have an alert if certain things happen. It's like, well, no, we're not like a burglar alarm company at all. We do have cameras. Some people automatically think remote supports mean cameras. I'd say it's a pretty small minority of cases where we use cameras, because we have about 60 different pieces of technology we can put in someone's house to know what's going on with them, to know if they're safe, to know if certain things are happening that are a concern, and that their parents themselves have let us know that they want to be alerted to. Cameras are obviously a lot more intrusive than having a sensor in your house, a motion sensor, an open close sensor, a stove sensor, those kinds of things. So cameras are a lot more intrusive. We can use them, and in some cases they're very helpful. And we have both indoor and outdoor cameras, video doorbells, if everyone agrees that those are needed. But it's really about the whole comprehensive service, which I'm going to explain here in just a moment, of providing a full complement of safety and support using assistive technology to guide our remote support specialists. It's not about the technology. It's not about, hey, we've got some neat gadgets. Let's put them in here and see how they work. It's tell us about the person, tell us about their needs, tell us about your concerns, tell us about the things that have happened in the past that you want to be alerted to, tell us the things that maybe haven't happened in the past, but you want to know about that to head off a potential problem. And we're going to put that into our support plan that generates alerts from all of these different sensors that we can put in someone's house to things that the family wants to be alerted to, or the individual themselves want someone to be alerted to. And I'll go into that in much more detail in just a moment here. Everything we do is a completely individualized plan for that specific individual. There is no cookie cutter formula. There is no, here's a package of assistive tech, let's do package A. We're going to do a very thorough consultation. We'd like to do it in person if possible. The pandemic has obviously changed that a bit. We do a lot of Zoom consultations now. It's up to the family, but we want to do a very thorough consultation to know about the person, their living environment, the concerns they have, their medical conditions, everything we can find out about the person, their communication style, their hobbies. The more things we know, the more effective our staff can be in supporting them and being a nurturing, caring voice. Not just a voice, but most of the people we support have a video tablet. So they're going to be able to see the person they're talking to. And again, I'll get into more detail in how this all works. But in general, it's that consultation, that thorough evaluation of a person's situation is the key to starting support. And we're very careful to let people know if this isn't a good fit. And there are situations where we'll say, you know what, this is just not a good fit for this person, could be for safety reasons. It could be, most importantly, they just don't want to do it. They don't want someone checking in on them. They don't want sensors in their house. They don't want to get a well-being call. And if they're not invested in it, they're not interested in it, they don't care about trying to enhance independence, it's just never going to work. And we're going to let the individual, their family know if we feel like this isn't a good fit. We have an extremely high retention rate after someone starts support. It's well into the mid 90% of people who start service are still on service 6 months later. And that's because, again, if it's not a good fit, we're going to let you know. It says a learning environment. We try to never be directive unless we have to. So we're trying to get people to make decisions on their own. We're trying to give them some tools to help them make decisions, to give them the confidence that they can make some decisions. So rather than saying, hey, you know what, it's 11 o'clock, I know you were thinking about a snack, but you're not supposed to have food late at night. It'll be more, what, it's really late. You think you should have a snack this late at night? What do you think? Or we see someone, doing something that's been a concern and we know it's a concern and they're not supposed to be doing it or something. We're not going to tell them, hey, don't do that. It's going to be more trying to get them to make the decision not to do it. Obviously, if it's a safety concern or something else, we'll be directive, but we're trying to do that as at a minimum and get them to make the decision on their own. Obviously, our staff is 24/7. They're there for anything the person needs. Most of the time, that's via a tablet that we would provide. It's a simplified tablet. You can't change the settings. You can't play a game on it. It's really push a button to make a call, push a button to receive a call. And the important thing about our remote support staff is this is not some call center that we contract with. These are trained professionals that are our own employees working in our remote support center. They're not working from home. So they have all of their colleagues around them to bounce ideas off of, to get input from. If one of our support staff is working with someone who maybe someone else has worked with extensively, they're going to be there to give them advice and counsel on how to work with that person. But I started with the company in that remote support center, and they're just very skilled, empathetic people, very good at knowing when to just listen, knowing when to just be quiet and listen, knowing when to read the person, to read their needs, to read what they need at that moment. Do they need us to be chatty and talk with them about maybe a hobby, or do they just need us to be quiet and listen? They're very good at that, at de-escalating situations, at maybe, if someone's having some anxiety or a bad day, maybe bringing up something that kind of gets them onto a different topic and kind of changes the tone of the conversation and their mood. So this is kind of a graphic representation of the sort of circle of support we would have. I'd say the weekly report you see at the top. Obviously, every call we have is documented. It's time-stamped. It's going to tell you who on our staff spoke with them, exactly what they talked about. We try to note the person's demeanor. Did they seem happy? Did they seem sad? Did they seem different than normal? And it'll document exactly what we talked to them about. Not verbatim, not everything, but we'll summarize the entire conversation. And that's going to be sent out weekly to whoever's authorized. You would also have access to an encrypted website where you would get a username and password where you could view those reports anytime you want. And that can be extremely helpful. Like if something's going on with someone, you can look back and see their history, see what they talked about in the past, see, hey, were their calls longer or shorter than normal? Did they mention something in those care notes that maybe will give you a clue to what's going on with them? So it can be very, very helpful, as well as the data from the sensors. What time are they getting up in the morning? How long are they staying in bed? How long are they sleeping? How often are they moving around the house? All of those things will also be accessible on a website that you have access to, can really give you a picture into how someone's doing, some background on maybe what's going on with them currently. So the bottom right are just some of the devices. Most of our devices are typical, off the shelf, not real complicated. You see we have a video doorbell. In the far right, the bottom with the red button, that's a personal emergency response system. It's basically a very simplified cell phone for when someone's out in the community and they need help. All of our devices are purposely very simple, not a lot of buttons, easy to operate. That device has a power button and that red SOS button you see in the center. The important thing about that is when they push that button and when they use a tablet to call us, or we're calling them for maybe a medication reminder or medication observation, whatever it is, it's always going to be someone trained in their ISP. It's not, again, not some random call center. Everyone's so used to, a call center where the person barely knows the company they're working with. These are people who work with people with intellectual disabilities all day long. And it'll be someone who's trained in that person's ISP every time there's an interaction with us. So when they push that button, they're going to always be greeted by name. It's got GPS, so we'll be able to see where they're at. We've had people use it to get bus directions. Hey, I'm lost. I need to know what bus to get on. Or, hey, I think I'm on the wrong bus. We've actually interacted with the bus company in some of those cases to find out what was going on. So it's for anything they need. Sometimes people will call just because they just want to chat with someone. More so on the tablet than that emergency device, but it's for anything they need 24/7 once they've got some basic remote support in place. That device can also be geo-fenced, the emergency button there, so that if they go into or out of certain areas, an alert's generated to whoever's designated that says, hey, they've gone into an area where we didn't think they'd be, or they've gone out of an area where you thought they would be. And then we're going to follow our support plan as to what action you want us to take. And everyone's support plan will be different as far as what action we take if we do get an alert like that. The device on the far left there is a motion sensor. It looks like an eyeball. It looks like it's cameras, but it's just a motion sensor. And again, the remote support staff, they'll see the person they're talking to, and they'll be able to see themselves in the bottom right corner there if they want to be seen. It's a tablet, so they just position, set the tablet on the, sorry about that. I thought I had that turned off. If they just position the tablet on the desk looking up, we won't see them. Or they just, cover the lens. Then we won't see them. It's up to them whether they're seen, but they'll always be able to see the person they're talking to. I've seen that be extremely helpful, especially for people who are on the spectrum. Just having that ability to talk to someone without having to make eye contact, without physical proximity, without some of the body language issues that for someone on the spectrum can really be a challenge. And I've seen people go from barely talking to me when I first started with them to having full conversations, tell me about their aunt and their uncle and the support person they don't like. And really, I think it was because they are able to get past some of those issues that proximity can bring up. This is a graphic representation of some of the places we might have sensors. I'll give you some ideas of what they might be. So in the bedroom there, we probably have an open close sensor on their bedroom door, a motion sensor in the bedroom, maybe a bed present sensor in their bed that would let us know when they get into or out of bed. If they have a seizure issue, we have a pad that goes on their bed that indicates if a motion that indicates a seizure is happening occurs, it sounds an alarm. We have a seizure alert wristband also that obviously designed to detect seizures. So those are some of the devices they might have in their bedroom. The important thing though is, what do you want us to do when we get an alert from one of those devices? So someone's support plan might say, you know what, if they're up out of their bed between 11 p.m. and 7 a.m., just give them a call and see what's going on, see if they're okay. It might say if they get up during those hours and they haven't got back into bed in 15 minutes, then give them a call. Or it might say, if they get up during those hours, give me as their mom a call. Everyone's plan is different depending on each person's needs. In the bathroom, we might have a water leak detector. We would probably have a motion sensor and an open close sensor on the door. Someone's support plan might say, hey, if they go into that bathroom or a bathroom and they haven't come out in 15 minutes, 20 minutes, whatever it is, then generate an alert. And that alert might go both to our staff as well as a family member, or it could only go to our staff. It could only go to a family member. again, it's just up to each person's support plan that we develop before we start support. You know, we might have a water leak detector in the kitchen and bathroom to indicate if there's an overflow. So those are just some of the typical places we might have sensors. And then we like to have as many sensors around the house as possible so that we can get a full picture of what's going on. If we have a question, we can see, okay, we know they're not in this room. We know we have a chair present sensor in this couch. We know they're not in the couch. If, you know, short of a camera, the more sensors we have, the better picture we can get of where someone's at, how long they've been there, if there's a concern that we need to respond to. In addition to those alerts, that's really the core of our system, are the alerts that the team sets at the very beginning of support. Tell us what you want us to be alerted to. Time of day that they go in or out. Again, going into a bathroom, change in kitchen use, change in bathroom use, whatever the team wants to be alerted to is going to be in our support plan. So this is some of the data from the sensors, motion sensors that someone might have in their house. So to give you an idea of how you know what someone's doing, this is a snapshot from 7:20 to 8:20 in the morning. We can see they woke up, prior to that 7:20 a.m. We would probably see, okay, there's no movement. We have a bed presence sensor. We know they're in their bed. So now, but we can see at 7:20 in the morning, they're up and moving around. They're going back and forth between the dining room, kitchen, and living room. They stayed in their living room from 7:35 until they moved to the dining room just before 8. The green door at the bottom tells us that they opened and closed their front door. If that door was red, it would mean they opened the door but didn't close it. But we can see they open and close their front door. 2 minutes later, they're back in their living room. And then, oh, sorry about that. Didn't mean to do that. And then a couple minutes later, they're here in the master bedroom. And then this man at the top shows us they're in their guest bathroom. So this looks like a pretty typical morning pattern. Probably would not have generated any alerts. But if this was 3 in the morning, their support plan may well say, hey, if they're up and moving around the house at 3 in the morning, give them a call and see what's going on. If you don't reach them, so every person we support is going to have a call tree, so that if we can't reach the first person to let them know, hey, we've been alerted to something that either you told us you wanted to be alerted to, or just something that our system's caught, who do we call if we can't reach the person to verify their safety? And we're going to have at least 3 or 4 people on that call tree. We're going to keep going down that call tree until we actually talk to someone, not just leave a voicemail, to let them know, hey, we had an alert, we haven't been able to reach the person to verify something, and then the team's going to determine what action to take from there. Our systems do have some artificial intelligence and machine learning built in. That's part of the patent on our software. And that identifies patterns that are out of the norm for that person. After a few weeks of support, the system identifies, hey, this is their normal time that they're moving around, their normal amount of bathroom use, kitchen use. And when it senses that things are outside of the norm, it'll send an automatic alert to whoever's designated saying, hey, seems like their bathroom use a little bit less or more than normal. And then it's up to the team whether that's something of concern or not, needs to be addressed. But it does have that predictive logic. They say predictive logic. It's really artificial intelligence, machine learning that lets alert you to, hey, something's a little bit different than normal. And again, just looking at this data can really give you some insight to how someone's doing. Are they staying in bed for 12 hours a day? Obviously, that might indicate a concern. Some of the devices on the top right there, that's the water leak detector with the 2 dots. This is a stove shutoff valve in the middle right. That would just automatically shut the stove off if it's on and there's no one in front of it for a certain designated number of minutes. We also have just if the concern about stove use isn't as drastic that it needs to be shut off, we have a sort of lower level device that would just trigger an alert. Hey, stove is on, no one's in front of it. And their support plan might say, give them a call and just see if they left their stove on. So we have usually, for several devices, we have a range of different levels of support. And then the bottom right there was just another motion sensor. This is just a representation of some of the types of individuals we support. Obviously, this is just 3 people that we chose at random. These names are made up. The pictures are made up. These are not actual people. The situations that you see there, the disability and the support plans, those are real, but the names and pictures are not. But you can see some of the typical things we support and how we address them. For Marty on the left there, he was leaving home. He had an elopement issue. So we have a lot of different sensors in place, especially door sensors with alerts in place, so that if he opens a certain door at a certain time, we immediately, get a hold of him or someone on his team, whatever the support plan says, to let them know that hey, there might be an elopement issue. But these are just some of the typical things we support and how we address them. A lot of it, again, it's based on those alerts that are generated at the time that we start support, and that the team tells us that they have a concern about and want to be alerted to. This is a video of Emma. Oh, there we go. Someone we support, and this is her mom and her talking about how she is able to live on her own for the first time in her life. I want to say she's right around 25, and their family never felt comfortable with her living in her own apartment because of safety concerns, the primary concern. And now they've got a whole bunch of different assistive technology devices, as well as obviously that support plan with us, that made her family feel like, okay, it's time for her to move on her own, which she's always wanted to do. So I'm going to play this. I know I need to share sound. There it is. And Teresa, I can see you. Can you give me a thumbs up if you can hear the sound once I start it?
Emma is a 24-year-old autistic. She has a seizure disorder, and she is what we refer to as unreliable speaker. I asked her if she could ever see herself living in her own apartment, and she said, yes, that's absolutely what I want for my life. And fortunately, early in that journey, we came across our friends at Safe and Home. The main thing we're using our Safe and Home tablet for now is for check-ins. We have to have a way to be able to check on her. She has to be able to reach out to us. Emma and her friends should be able to go out for a walk by themselves. But with all of them wearing the device, we know if anything goes wrong, we could always find them with the GPS system. I mean, we cannot fake the joy that she is experiencing in her life. I mean, she is living a self-determined life. This is what she wants, and she's doing it, and we could not be prouder.
Gosh, that was not the video I was expecting. It's much shorter. It's about a 5-minute video of her mother going into more detail. And I forgot that this was the shorter version, but it gives you a sense of how much of a life-changing help this can be. And, look, I work for the company. I'm obviously a little biased, but the reason I work for this company is I started in remote support, and I've just seen so many people be happier, be more confident, be more talkative, social, develop conversational skills by having that confidence that comes with feeling like, hey, I'm much more capable than anyone ever gave me credit for. And this can really be a tool to help achieve that. And that's why I do what I do. And we have a YouTube channel, Safe in Home. If you go to YouTube, type in Safe in Home, you'll see about 15, 20 different stories like that of people talking about how this has changed their life. So what I want to do now is give you some real life examples of people using our systems and how they use them and how it's impacted their life and help them stay more independent and safe. This is Lorenzo is someone we support who has a seizure disorder. He was having seizures very regularly. And that was obviously a huge impediment in his life and living more independently. So we have that seizure alert bracelet that you see there. He's also got a pad in his bed that sounds an alarm when it detects a seizure. But this is an example where that artificial intelligence identified that on the day of his seizures and the day prior, that his bathroom use was less than normal. So the team decided, I wonder if dehydration is one of the triggers for his seizures. So they changed the support plan, put in reminders to drink water in the morning and in the evening. And just by doing that, we were able to drastically reduce the number of seizures he was having. And it turned out that dehydration was a major trigger for his seizures, and just drinking water ended up being a huge, help for him and reducing the number of seizures he has. So that's that's one of the seizure management devices that we have. Medication compliance is a huge use of remote support. It could be anything from us visually observing someone taking their medication. We have people who will hold up a packet of pills with the date and time on it to the camera. We confirm it's the right one. We watch them take them, drink some water. Or it could be just a reminder call on the tablet. Hey, remember to take your medication today? And obviously it's going to be noted in their care notes what their response is. It could be escalated so that maybe they're telling us they're taking their meds, but we find out, the team finds out that they're not. Hey, let's change it to a visual observation. And that's something I should emphasize. This is, once we develop the support plan, it's a living document. It's not like the support plan's in place and hey, that's it. You can change it. You can call us up and say, hey, on Friday, they're not going to their day program. We need you to do a check-in call, to make sure they're okay. Or, we need to add a check-in call on this day because they're going to a movie or whatever it might be. So it's a living document. You can change it whenever you need to. We like to get 48 hours notice if you're going to change something, but in an urgent situation, you can call up and say, hey, I need you guys to do a check-in call tonight. So it's a living document that changes as their needs change. And again, you'll have a client services representative assigned to each person that would put changes like that in place. So this is someone where medication compliance was a big issue. And we were able to give her a medication dispenser that sounds an alarm when she's supposed to take her pill. We had a visual observation with her to make sure that she was taking her medication. And we were able to, drastically improve her compliance with her medication schedules. Elopement is another major use for remote support. And, it says someone no longer interested in overnight staff. We get a lot of that, of people saying, man, I just want some privacy. I don't need someone in my house all the time. And I talked to Teresa a little bit about a lot of the people in your school have 24/7 support because they have medical needs. They have 24/7 support. And this could be a tool to not necessarily replace that 24/7 support, but to just maybe give them a little privacy, give them some time where maybe they're apart from that nurse. Maybe they're on their own for a couple hours a day to see how they do. Maybe they just want to be on the porch by themselves and not have someone kind of hovering over them, making sure they're okay. Maybe so they have that, maybe they have that emergency button. Maybe they have a camera on their porch to achieve some of those desires. But Joseph is someone who used to like to go out on walks at 2 in the morning. And his main thing was he just wanted someone to talk to. So we knew that. We got to know Joseph, and we would just say, hey, Joe, we did this with someone where everyone agreed that cameras were needed. So we would see him getting ready to go outside. He kind of had a pattern. And we would start talking to him through the camera and say to him, hey, Joe, it looks like you're getting ready to go outside. What's going on? And we'd engage him in conversation. And most of the time he'd forget about going outside entirely and just talk to us. And again, we're trying to get him to make that decision on his own, develop decision-making skills. After school, again, typical use of remote support. Child comes home from a day program or school or work or whatever it is, and they're alone for 2 or 3 hours until their parents get home. Extremely hard to find a provider that's going to staff a 2 or 3 hour shift. So we can fill that in. We can do a check-in call during those hours. We can have motion sensors and a support plan in place that triggers alerts for maybe if they go outside, maybe if they do certain things that the family has said, hey, I want to know if they do this. Jason has a facial recognition doorbell. So there were certain people who his family did not want visiting when they weren't there. And so we had facial recognition recognize when that person was present, and we'd be able to talk to them through the doorbell and let them know that they're not supposed to be there. Jenny is someone who just wanted some time alone, had some issues with her staff. We find this a lot, that there's just staff members that they don't get along with, but that staff member has to be there because the family or the team feels like, well, we have to have someone there. And in a lot of cases, we're able to replace that person, at least for a portion of the day, with remote support and give them some of the time alone. And a lot of times we find that the behavior issues were because of their issues with staff, and you replace some of that staff time with remote support, and guess what? The behavior issues also start to decrease. Fall risk mitigation, again, major use of remote support. This is a lot of times a case where cameras are can be helpful so that we can keep an eye on someone. We can see if they have fallen, but that's another typical use of remote support is for fall risk. This is a weekly report of someone's bed presence from their bed presence sensor. And again, just valuable information that can give you a sense of how someone's doing. So, you know, a support coordinator or someone else, a family member, team member might look at this and say, boy, I wonder what's going on May 7th. They were in bed from midnight until they were in bed for almost 24 hours. So again, probably, you know, you need to find out what's going on. Now, who knows? Maybe the team already knows what's going on. Maybe they don't. But seeing someone's sleep patterns can give you a very good idea of what's going on with them and if something needs to be addressed. Our staff is trained in acceptance commitment therapy. We have a psychologist on staff that does regular trainings with our remote support specialists. And you can see some of the things I've already mentioned there, the things that our team tries to do. They receive the same training that DSPs receive in 3 different states as well. And again, just really skilled, empathetic people who are really good at reading the situation and being able to calm someone, de-escalate things, talk in all the conversations are very friendly, non-clinical, not clinical at all. It's more, hey, Mike, how's it going today? Everything going all right? It's very conversational, very friendly. And a lot of times that alone can be a huge help for someone, is just having a friendly voice that they know someone who cares about them, is checking in on them, can talk to them about anything they want. And again, it's available 24/7. They can talk to someone whenever they need to for as long as they need. You can see some of the care notes, the typical care notes that someone might have. And you can see the second one down said, appeared cheerful and smiling tonight. We try to note their demeanor, try to note if there was something out of the ordinary for them. Again, you'd have access to this through a heavily encrypted website if you wanted to, anyone authorized it, wanted to see the care notes. Almost done here. This is the second to last slide. These are some of the typical things we support. Obviously not a comprehensive list, but a lot of the very common situations that we support and use remote supports for. And I've talked about a lot of those already. I'm going to open it up to questions here, and I'm going to put my contact information there. Please, you know, there's not a lot of family members on this presentation, so not a whole lot of opportunities for family members to ask questions. But if you have anything, if you need more information, if you have specific questions, if you want to talk about specific things to your situation or in general, please email me, give me a call. Either way is fine. That is a California phone number, but I do live here in Pennsylvania and King of Prussia, so I'm nearby. And I'll go ahead and open it up to questions.
First of all, David, that was really wonderful. Thank you. It's incredible to learn about what has come out in just even the past few years. I do have a couple questions. Question 1 was about funding. I know you had said waiver funding, I believe. Are there any other funding options or sources? I know some of our families get waivers, some of our families do not get waivers. Is there ever a private pay or working? I know a lot of our families get community health choices, which is more like insurance funding. So I was curious about funding options.
Sure. So the vast majority of people we support are on one of the ODP, Office of Developmental Program, Medicaid waivers. We are in the process of qualifying with the Office of Long-Term Living for the community health choices, OBRA, Act 150 waivers, and it is a long process. We've been at it, I think, right around a year. I am hoping we're close. But boy, every time I think we're close, we get another long email with a whole nother list of requirements from someone else in the bureaucracy. There's 2 different bureaucracies you have to go through. So I'm hoping we're close. Private pay is definitely an option. Unfortunately, insurance just won't cover this. They just, for some reason, they found a way to say, no, not covered under your insurance. But those are really the options, waiver or private pay. And you know, as far as the CHC waiver, I think Teresa mentioned that a lot of your families are being directed to that. You know, I'd love to say by the end of the year, it's possible. I'm hoping, if not, early next year.
Okay, thank you. That's very helpful. And just to know that this is out there and then be able to give it to families as a resource and option to explore. The other question I had was, so many of our families, many of our students have one-to-one nursing overnight. And it might not be something that families feel comfortable letting go of, but things like this would offer an added layer of support. Have you ever seen any scenarios where the funding pays for both nursing and these type of services as support, or any way you would envision it could sort of enhance the nursing experience? Because very scary walking out of a room sometimes and leaving your adult child with another individual in their care.
Sure. So in general, ODP, because of Centers for Medicaid and Medicare Services rules, doesn't like to see both remote support and direct support in place. But there are cases where they will approve that. It's on a case-by-case basis. And if you can demonstrate, hey, look, there's a need for a 24/7 nurse, but we also want to try and give them a little privacy. We want to give them some time on their own, or maybe a nurse isn't in line of sight. It's going to be a case by case whether ODP would approve that. But if it's medically necessary for them to have 24/7, skilled care, it's possible that they would approve this in addition to that. It's just case by case.
Thank you so much for that.
So I have a question when it comes to seizure management. Is it something, so if somebody, they don't need you around 24/7 and it's going to be a sporadic, no one knows when it's going to happen. It could happen once a month. Is there like different pay levels for different needs? So if somebody needs somebody for 2 hours in the afternoon, as opposed to just a monitoring in case they fall or have a seizure?
So we have two different devices. One is a seizure alert wristband that you wear like a watch. You saw a picture of it there. That would generate an alert as long as you're wearing it. It would generate an alert if it detects a seizure or motion that indicates a seizure 24/7. That would be in place 24/7. Now, in order to have that, they have to have a minimum number of hours of active remote support where we're monitoring all the devices. We're doing check-in calls. And in general, our minimum is 21 hours a week. Sometimes we'll approve 14 hours a week. But once you have that minimum number of hours, they now have 24/7 support, 24/7 ability to use the tablet to call our staff for anything they need. And we're monitoring that device 24/7. I shouldn't say monitoring. We're responding to alerts from the device 24/7. The other device we have is a seizure alert pad that goes into someone's bed. And that does not generate an electronic alert. It generates an alarm. It sounds an alarm when it detects motion in someone while someone's sleeping that indicates a seizure is happening. So it would sound an audible alarm in their bedroom. It's also got a remote alarm where, let's say the person is downstairs in a bedroom and someone upstairs want to be alerted that has activated. So there would be a remote alarm that would not only sound an alarm in the bedroom where it's occurring, but maybe on the second story or wherever else that other second device is. Does that make sense, Kristen?
Yeah, sorry, there's like all these ambulance and lights right outside our house just as
Oh,
we're
no problem.
talking. So it was a little like, what's going on?
Right,
I need
right.
you to call them. So is it a individual pricing plan? There's not like a set thing. Is it each person's going to get their own price plan, or is this something that's
Yep.
like 14 hours is this, or this is?
Yeah, so there's two different components. One is all of the devices are leased. All of the assistive tech devices are leased rather than sold. And that's because that covers everything: installation, training, tech support, tech visits, replacement. Everything is covered for the lifetime that you have the service. The more sophisticated the device, the more interaction it requires on our part, the more it is per month. And it ranges from, a typical motion sensor is like, I think $8 a month. The tablet, which gives you 24/7 access to our staff, is like $44 a month. A motion sensor is about $8 a month. So you might have anywhere from $25 or $30 a month in assistive tech devices to a couple $100 a month. And then the other component of the charges are the hours of active remote support. And that means our staff is receiving alerts from the devices. monitoring the devices, doing check-in call, doing medication reminders, whatever it is the staff has asked us to do, that we're actively engaged, monitoring the devices, doing what you want us to do. And those hours are charged at $6.88 per hour. So once you have at least 14 to 21 hours a week of that remote support, now you have 24/7 access to the tablet, to us monitoring that seizure alert wristband. There's certain devices that we monitor 24/7, smoke alarms, seizure alert wristband, water leak detectors, and a few others where we're responding 24/7. Doesn't matter if it occurs outside of those hours of active remote support.
Thank you.
Mm-hmm. So we call those hours where it's not active remote support, on-demand support, where, hey, we're not watching the devices, we're not receiving alert from the devices, but we're here for you. If you need to call us, if something's going on, you know, if you need us to do something for you, we're going to do it. And then during those hours of on-demand support, the alerts can go to a family member. So like, let's say you want to be alerted if they're they go out. And we're only doing active remote support for 2 hours a day. So during those times where we're not doing active report, you can say, hey, I want the alerts to go to me as their mother or their brother or their sister, whoever it is.
David, I had a question about age ranges. So I know that one would need to have one of the waivers, hopefully CHC at some point soon. But do you ever, so Safe and Home would not begin until someone was at least 18 years old, or is that not correct?
We have a few people we support who are like, I think 9 and 10 years old.
Oh,
you know,
wow. Okay.
Yeah, I mean, the main constraint usually is that people want the waiver to pay for it, and you can't get on a waiver until you're 16.
Sure.
So, but we can support people who are under 16.
Got it. Okay, no, thank you. And that would mostly be through private pay or, I don't know, an alternate funding source or something.
Yeah, yeah. I know that the ODP waivers, they're all at least 16. A couple of them are 21 where you can get on it.
Right. Okay, thank you for that.
Any other questions? No. And we do have a website, safeinhome.com. We have a YouTube channel. If you type in Safe and Home, you'll see a bunch of videos, much better than what I showed there of Emma, of people just talking about how they use us. And, you know, I don't think we have a video. I think almost all of your students are in wheelchairs. We don't have a video of someone in a wheelchair, but really not that much different. You know, for someone who's in a wheelchair, we can actually put a chair sensor in someone's wheelchair that, again, an alert can be generated if they fall out of their chair or get out of their chair for one reason or another. That we could have a pad in their wheelchair that generates an alert if they're no longer in that chair. So what else do we have? YouTube channel, webpage. There's something else I'm forgetting. I can't remember, but those two resources will give you a ton of information about what we do. And you see my email and phone number there. I'm always available.
Last question. Do you ever lease devices that can just be alerted to family members and not be monitored by the company?
Sure. We can do assistive tech only where you don't have any remote support hours. All the alerts just go to whoever you want. And then, but our field service staff still maintains, repairs, replaces, does tech support for those devices. So yeah,
Okay,
that is an option. Now there's a couple of devices where we require remote support hours. The tablet, again, 14 to 21 hours a week minimum. The personal emergency response button, and 2 or 3 other devices where if you have that device, you have to have a certain minimum number of hours of remote support, because otherwise, why do you have the device? You know what I mean? If you want to connect to our staff, you know, we want to have a minimum number of hours. But most of the devices, the vast majority, you don't have to have any remote support hours.
Great. Thank you.
So David, do any in-home support agencies work with you folks to build in what I would say is to augment their staffing, to provide coverage of individuals that don't need constant supervision, but might need a check-in from one of their own staff. You know what I mean?
Yeah, oh no,
So
absolutely. Very common. I'd say, a large portion of the people we support are in a situation like that where they have a provider. Maybe the provider's having trouble with staffing. It's really a bad situation right now. There's a lot of shifts going uncovered. There's a lot of supervisors, executive level people having to go out and cover shifts. There's a massive staffing shortage right now. So we have a lot of providers using us to fill gaps in coverage, to replace overnight staff, instead of having someone sitting on someone's couch while someone sleeps. We can almost be better in those cases, because if you have someone in someone's living room while they're in their bedroom with their door closed sleeping, that person in the living room doesn't know if they've fallen out of bed. They don't know if they got up and went to the bathroom that they have in their bedroom. We'll know those things, and we can can be alerted. We can actually, sometimes we've alerted the staff sleeping in the living room, hey, they got up out of bed, where they don't know because the bedroom door is closed. So yeah, we work with providers a lot for those situations I described. In some cases, we're replacing whole shifts. Some cases, we're just covering a few hours that they can't staff. I mentioned, kids coming home after school. Very common for a provider to say, look, we can't send someone out for 3 hours. It's just not economically feasible for us. But hey, here's remote support. We can put all these mechanisms in place so that they're covered for those 2 or 3 hours. And then we can send someone out for, the 6 or 8 hour shift after that.
gotcha. Thank you. And then if there's multiple people in a home that have different levels of support requirements, you would just look at what suite of solutions would need to be deployed in that home. And
yeah, each person would have their own support plan. Each person would have their own consultation. I'm working with a house right now in Philadelphia through a company called Spin, who's doing a pilot project with us, where there's 3 older gentlemen live in a house. Each guy, there's a lot of devices that are used jointly by them, all the motion sensors, all the open close sensors, the water leak detectors are they're all using those, but then they each have their own individual devices, their own individual support plan, when we're calling them, what we're talking to them about when we call them. So yeah, we would have a support plan for each person in the house.
that's good to know. Now, if those individuals, maybe there's different levels of staffing requirements in the home, and they might have their own waiver,
They do.
but they might not have an agency per se that's governing the home. How does insurance look at that, and how does the waiver separate, tease that kind of stuff out?
So in general, insurance will not cover this, which I think I can't understand their rationale for that. But in general, insurance companies won't cover this. A lot of times in that situation, like the situation I just described with Spin, that's a community living arrangement where the agency owns the house. They receive a daily rate for taking care of each person. And the daily rate that providers receive includes remote supports. So they're already getting paid to technically provide remote support, even if they're not doing it yet. So in those cases, we bill the waiver for the assistive tech devices, but we bill the provider for the active remote support hours, because they're already receiving money in that daily rate for the remote support hours. So if we were to bill for those, CMS, Center for Medicaid, would be like, hey, you guys are double billing. We're already paying the provider for remote support. So that's the way it works in that situation. Now, if you had 3 people living in a house, each on their own waiver, a provider, it's not a community living arrangement. It's not a situation where a provider is receiving a daily rate. They would just each have their own plan. We would bill each of their waivers individually for their particular services. We bill directly through ODP's Promise billing system, the electronic billing system. So we would just be billing each person's individual waiver for whatever it is they have.
Gotcha. Okay. Thank you for actually inferring what I was trying to ask.
Yeah.
Good job.
Yeah.
And thanks for the presentation. It was very helpful.
Yeah, no problem. Bob, do you have a child at HMS, or are you
Yes, I have a daughter at HMS who's 19. She's relatively independent in terms of some of the things she can do, but she's really relying on somebody being in the home for helping her with her ADLs. But I do have a son who's ambulatory, has some visual issues and IDD and autism. So some of the stuff you're talking about is really up my alley as far as his needs go. And then my wife has some issues as well. So there's some monitoring things that would certainly benefit her if somebody's out of the house for an extended period of time or something like that. But it's for my son down the road that I really foresee this kind of technology being of service.
great? Yeah, whenever you're ready, just get a hold of me.
Yes, sir. Thank you.
Thank you. Any other questions? No?
Well, thank
Okay.
you so much for joining us tonight. And I will be sending this out to everyone who is maybe watching the Phillies right now. And we'll make sure to share your contact information as well so that people can reach out if they have additional questions.
Great, I appreciate it. Thank you very much. Really appreciate the opportunity. And again, let people know, no problem to just talk in general. No problem if you think, oh, well, I don't think this will work for me. And a lot of times I've found that people think that, and we're able to find a solution that works for everyone. So.
Great. Thank you so much. All right. Well,
Thank you
everyone
much,
have
guys.
a lovely-
I'm going to stop sharing here. I don't know if your meeting's going on, but I'm going to leave here. And have a great night, everyone. Thank you very
All right,
much.
Good night.
You too.
Bye-bye.
Thanks.
Okay.